Bom dia. Agradecer a presença de todos. Agradecer o Dr. Robin Carhart-Harris, que aceitou gentilmente o nosso convite. O Robin ele tem doutorado em psicofarmacologia pela Universidade de Bristol e hoje é pesquisador, pós-doutorando do Centro de Neuropsicofarmacologia da Universidade do Imperial College London, de Londres, né? Ele coordena um projeto intitulado Psilocibina para a depressão. A psilocibina, para aqueles, se alguém não conhece, é um princípio ativo dos cogumelos do gênero Psilocybis, né, os chamados cogumelos mágicos, e eles têm desenvolvido pesquisas muito interessantes com ressonância magnética funcional. Ele vai explicar para a gente agora. Então, Robin, por gentileza.
Okay, well, thank you very much for the invitation to be here. It's a real pleasure to speak to you. Hopefully you'll find my research interesting, and hopefully it might inspire some of you to look into this area yourself. So, let's see how we go with the pointer thing. Where should I be pointing this? It doesn't seem to be working. Sorry? Oh, really? Okay, yeah. So, here we go. It's working now. So just to begin, I'll give a little bit of background on psilocybin. So first of all, this isn't going to be very easy. So it was, it's had thousands of years of ceremonial use. Next click, please. There's going to be lots of clicking, unfortunately, and this isn't going to work very easily. So before 1957, Gordon Wasson, who was actually vice president of J.P. Morgan in the US, a banker, he was also an amateur mycologist and had an interest in mushrooms and learnt about psilocybe mushrooms and their ceremonial use in Mexico. And so with his wife, he went on an expedition to Mexico in search of these of the ceremonial use of magic mushrooms, and it was there that he met the now famous curandera Maria Sabina, and he had an experience with psilocybe magic mushrooms. Click, please. Yes, so in 1957 there was a famous article in Time magazine where he documented his experience in Mexico with Maria Sabina. Click, please. In 1958, they cultured some psilocybe mushrooms and provided them to Albert Hofmann, who is the Swiss chemist who is most famous for discovering LSD. And Hofmann was the first to isolate the psychoactive ingredients of magic mushrooms, psilocybin, and its metabolite, psilocin. So in 1959, Hofmann also synthesized psilocybin, and in 1962, Wasson invited Hofmann to travel to Mexico, and they actually provided Maria Sabina with the isolated, pure, synthesized psilocybin, and she was quite skeptical. She thought, this is going to be quite different to the mushroom experience. There's something special about the mushrooms, and this pure ingredients of the mushrooms isn't going to produce the same effects, but in fact it did. They actually gave her quite a large dose, 30 milligrams, and she said, yes, this is essentially identical to the mushrooms. So next slide, please. So some more scientific background. First of all, I've already said psilocybin is found in magic mushrooms. That's a liberty cap mushroom. Here are the molecular structures. Now, psilocin is the metabolite of psilocybin. Psilocybin is the more stable phosphorylated ester of psilocin. So it's psilocybin we work with really because of its stability, but as soon as it's in the blood, it seems it's broken down into psilocin, and it's this that works on serotonin receptors in the brain, as I'll talk about in a moment, which is the first stage of the mechanism of action of psilocybin and psilocin. Here are some other structures. DMT, that's found in ayahuasca. Bufotenine, that's found in some toads that secrete bufotenine, and it's another psychedelic substance. And what's remarkable when you look at these structures is their similarity to this very important endogenous neurotransmitter, serotonin. So if we look at bufotenine, it's essentially the same apart from this dimethyl group here. So it's remarkable that such a subtle change in molecular structure can confer such profound effects on consciousness when these compounds are given, and yet there's serotonin floating around in the brain doing all these fundamental functions. Down here we have, this was a finding in the late 1980s, and really it was a very crucial finding in the understanding of how these drugs work in the brain. And it was found that the affinity or the stickiness of a psychedelic drug for a particular serotonin receptor, the serotonin 2A receptor, correlated with its potency. So the more sticky or the higher affinity the psychedelic, the more potent it is. And to help illustrate that, LSD is a good example. It has a very high affinity for the serotonin 2A receptor, and it's incredibly potent. So in doses as low as 20 micrograms, it's psychoactive. Okay, next one, please. And it's also been found that if you block the serotonin 2A receptor with ketanserin, a relatively selective serotonin 2A receptor antagonist or blocker, then you'll significantly attenuate the key psychedelic effects of psilocybin in humans. Now, where is the serotonin 2A receptor? Well, it's very much a cortical receptor. It's expressed in relatively low concentrations in subcortical regions, but it's densely expressed in the cortex, and importantly, particularly highly in high-level cortical regions concerned with high-level cognitive functions, such as the posterior cingulate cortex, and that will become quite important as we go on. Most of my work is neuroscientific, so that's what I'll be presenting, really, how these drugs work in the brain and what we learn about that in terms of implications for applications in psychiatry. But another little bit of background, it's interesting to know where the term psychedelic comes from. Psilocybin is a classic psychedelic drug, like LSD, like DMT. It's really these serotonergic hallucinogens that are referred to as classic psychedelic drugs. So psychedelic is a term that was coined in conversation between the famous author Aldous Huxley and a psychiatrist working with LSD in the 1950s, Humphrey Osmond, and they were looking for a better term that could really sort of capture the essence of what it is that these drugs do. Huxley came up with a term, but it was a little bit clumsy, and Osmond suggested combining the terms for soul or mind, psyche, and delicy to make visible or clear. So it was from that they came up with the term psychedelics, which literally means mind manifestors or soul revealers. So already sort of inherent in this term is what these drugs are doing psychologically, that they sort of allow for the emergence of psychological material that is usually kept from consciousness. So they make manifest latent psychological contents. So that's what these people wanted to communicate to people in terms of the name for the drug. So the next slide, please. So this is Stanislav Grof, who did a lot of work with LSD in the 1960s, and he comes up with some great comments in his books, and they're often quite grandiose, but they're useful for expressing why these drugs are so interesting. And so he said of psychedelics that used responsibly and with proper caution would be for psychiatry what the microscope is for biology or the telescope for astronomy. These tools make it possible to study important processes that under normal circumstances are not available for direct observation. So what a incredibly grandiose claim to make a sort of a link between psychedelics in psychiatry being equivalent to what the microscope has been for biology. But if there was even any sort of glimmer of truth in this, it's an incredibly important matter, and you know, it really supports why we should be looking at these drugs. So next slide, please. So for those who don't really know about psychedelics and the evidence about their harms and also potential therapeutic benefits, it's useful to address some people's perhaps preconceptions about the harm potential of these drugs. And so this image here shows a number of studies that have reviewed a number of different drugs and ranked them according to their potential for harm. And so this was done famously by my boss, Professor David Nutt, and a couple of articles were published in The Lancet, for instance, a leading medical journal. And here was a analysis we did surveying experienced drug users. So we took close to 100 experienced drug users that had personal experience with all of these different drugs here. They're quite hard to see, and then we asked them to rank them according to their perception of their potential for harm. They ranked alcohol as the most dangerous drug of all these. You can see there's heroin, cocaine in the list. Bottom of the list was magic mushrooms for harm potential. Above that, cannabis, LSD, MDMA. But it's interesting, I think, to kind of convey the harm potential of a drug, to do it in a relative sense. It's very difficult, you know, all drugs have a potential for harm, but in order to really sort of get a sense of the seriousness of a drug's harm potential, it's useful to put it in a context, and that's what David Nutt has done here, and this is what we did when we surveyed drug users' opinions. And really, we saw a strong correlation between these drug users' ratings and also ratings from scientific experts when they assessed the harm potential of a number of different drugs. So there was a strong correspondence. Magic mushrooms often came out as the lowest in terms of harm when compared against these other drugs. Okay, next slide, please. Also, this is a useful reference if you want to get a sense and get a feel for reviewing the harm potential of psychedelics. And this was a survey of a large sample of individuals in the US, 120,000, I think it was, and around 20,000 were users, had previous use of psychedelics, and they found that within this population there was no elevated rates of mental health problems. So a indirect evidence for the argument that psychedelics aren't especially harmful drugs, and they may have some potential for benefits. So next slide, please. So in terms of their potential for benefits, here are some controlled studies that have looked at that, sometimes indirectly and sometimes directly. So indirectly, Roland Griffiths at Johns Hopkins in the US has done some very nice studies in healthy volunteers giving high doses of psilocybin. And he's found that with a single acute administration of a high dose of psilocybin, when they followed up these individuals some 40 months later, this was a controlled study, they had an active placebo, methylphenidate, as the active placebo. They found that within those given psilocybin, 60% rated their experience within the top 5 most meaningful experiences of the whole of their lives. So to put this in a context, they would say it was comparable to things like the birth of their first child or their wedding day, to major life events that leave a lasting impression. They were describing their experience, a single experience with psilocybin, as being equivalent to that. They also found that some 60% reported improved sense of well-being and life satisfaction. And this actually correlated with the prevalence of spiritual type experiences. So when they met certain criteria for assessing a mystical type experience, they also reported improvements in well-being and life satisfaction that seemed to last as well, that seemed to be persistent. And again, it's quite remarkable. This is with one single dose of psilocybin. So clearly there's something happening here, and it seems to have a lasting effect. And also it seems to be positive. There weren't any cases of decreases in well-being or life satisfaction. It's important to emphasize that. So Catherine McLean from Roland Griffith's team also looked at people's personality ratings. They looked at baseline, and the volunteers did the ratings. Then they looked I think it was 18 months later in this case. And they found that a certain personality trait, openness, which kind of indexes sort of openness to new experiences, creativity, sort of flexibility in thinking, they found that this particular trait was significantly increased some 18 months after a single acute experience with the drug. Now, this is quite unusual because in adults, our personalities should remain relatively stable. There's a strong test-retest reliability with these personality scales. Our personalities should be relatively fixed by adulthood, yet they were seeing these significant increases, and they were evident 18 months on from a single experience with psilocybin. So clearly the drug does something, and the effect seems to be lasting. So in a controlled study looking at patients now, Charles Grob at UCLA, he was looking at patients with anxiety related to end-stage cancer, so anxiety around death. And he found that, again, they gave psilocybin a single dose, not as high as Roland Griffiths had been giving, but they looked at anxiety ratings, and 1 to 3 months post administration of psilocybin, they found that anxiety scores were significantly reduced. Then 6 months after the experience, they found that depression scores were significantly reduced as well. So again, this time in a patient population, we're seeing improvements in these indexes of mental health. Also, there weren't any adverse events in terms of psychological adverse events in this study. An earlier study, Moreno, he looked at obsessive-compulsive disorder and found it's slightly less compelling, the results from this study, but he found some evidence of short-term and some persistent improvements in symptomatology in obsessive-compulsive disorder. So next slide, please. Again, this is, that was going back, yes. So this has also been found with ayahuasca. I just wanted to say that there hasn't been so many controlled studies with ayahuasca. Perhaps that's something for you guys to take up. But this looked at users of ayahuasca in, I think it was the Santo Daime church in Brazil, and they used as controls people who were attending religious ceremonies but without the drug, and found that those who were partaking in ayahuasca ceremonies had lower rates of mental health problems. So next slide, please. So a survey that we ran, just to give you a qualitative sense of some of the things people say in terms of their use of magic mushrooms and how they've been helpful for them. This individual at the top, this is from a survey that we ran, sampling users of different drugs, and this individual, referring to his use of magic mushrooms, said, it opened my mind, it helped thoughts flow more smoothly, it gave me a sense of well-being. This one said, mushrooms allowed me to see how connected the world was, how intricate and beautiful, a sense of affiliation with animals and nature. It lifts my mood. This individual said, mushrooms act as a reset for me. Mushrooms rid my depression for months after use. Ketamine does the same. There's some evidence that ketamine has some efficacy, some short-term efficacy in treating depression, and particularly treatment-resistant depression, so very stubborn depression. So he's saying here that ketamine does the same for about a week. Ecstasy does it, that's MDMA, does it for the time that I'm on it, but no SSRIs, Seroquel, that's quetiapine, a kind of antipsychotic and antidepressant, or Xanax, which is a sedative benzodiazepine, have ever helped my mood and usually have me thinking about suicide, along with a plethora of other side effects. So that's interesting when he's referring to his established medications, and how mushrooms have been superior, in his view, to these established medications. Another thing that would support the therapeutic use of psychedelics is that they could be administered in a single dose. And so in terms of side effects that you tend to associate with chronic use of a medication, you don't have that issue with a single administration potentially of a psychedelic. So it has that advantage. Clinically it has that advantage, but in terms of developing this, marketing this for the drug companies, that's arguably a limitation. So that's one of the problems about rolling out these treatments, and also in terms of having this work financed, this research financed, there's less of an incentive from the pharmaceutical companies to support it. So for us, we've often had to get independent funding, but recently we were fortunate to get some medical research council support in the UK for a depression study. But this last one says, after I had an experience with LSD, magic mushrooms, or ketamine, there will be several weeks after which I feel as if I'm a brand new person. More so with mushrooms, followed by LSD, and least so with ketamine. Magic mushrooms have helped me in many other ways as well. It lets me recognize some of the negative patterns in my life and change them, and no SSRI can do that. So next slide, please. So this is really the basis of my own work. How does psilocybin affect brain activity to change consciousness? So this is really the sort of primary focus of my own research. Yep, you can click through. So this is the first brain imaging study we did with psilocybin. It looks at change in blood flow in the brain. Next one, please. 15 healthy volunteers, mean age of 34, 18-minute scan. We had a placebo scan and a drug scan. The conditions are task-free rest, so they have their eyes closed. There are no behavioral paradigms constraining what they do. We're just looking at spontaneous brain activity as it plays out, sort of in an undirected way. We give 2 milligrams psilocybin. That's equivalent to about 15 milligrams of orally administered psilocybin. We give the drug intravenously. It's methodologically advantageous in terms of doing brain imaging work, and it produces essentially the same effects as orally administered psilocybin. So it could be described as a moderate dose, 2 milligrams intravenous. And essentially the design is we have a baseline pre-drug period. We infuse the drug over 60 seconds. People start feeling the psychoactive effects almost immediately at the end of the infusion. So they rapidly come up on the drug. And then we essentially look at changes in brain blood flow post-infusion of the drug versus pre-infusion. Next slide, please. And these are our primary results. So what you should immediately see is that there are only changes in one particular direction, and that's actually, perhaps surprisingly, in the direction of decreases in blood flow in the brain. And what's more is that these decreases seem to be localized to particular regions. They're relatively widespread, but the regions in which they're localized are important hub structures in the brain, such as the thalamus here in the middle, and also cortical hub structures such as the posterior cingulate cortex. Remember I told you that there's a particularly high expression of the serotonin 2A receptors there, which are the ones that psychedelic drugs work through. So high expression of 2A there, and this is where we're seeing decreases in blood flow with psilocybin, and also in a medial prefrontal hub structure of the brain. So that was the main outcome, and what we inferred from that, if you click on please, is that the function of a hub is to really integrate information. So information from different regions of the brain will all come together in this common center. So its function could be compared to, for instance, a capital city in a country. That works best in terms of the UK because London is a kind of key center. So it's where things kind of come together and information is pooled and integrated. So that would be the function of a hub, and that's where we're seeing the decreases in function with psilocybin. And what might that mean in terms of the changes in consciousness? Well, we're linking it to a very common description of cognition or consciousness becoming more flexible under the drug. It's kind of the normal constraints on cognition are reduced, and as a result, consciousness is more flexible, it's unconstrained, and imagination is enhanced, and this kind of thing. Potentially also creativity. If you just go back, and this volunteer, just to help express what that might sort of translate as in terms of personal experience, this volunteer said there was a definite sense of lubrication, of freedom, of the cogs being loosened and firing off in all sorts of unexpected directions. So that helps to sort of express the principle here that I'm trying to describe. Click on, please. So another analysis we did is functional connectivity, looking at temporally correlated brain activity in different regions of the brain. So for instance, you have brain networks in the brain, and within these different regions, which are sometimes quite spatially remote, they're quite distal from each other, quite far apart, yet their activity is correlated. And so what this tells us is that these regions function together as a network which serves a particular function. So we looked at a number of different networks in the brain and how the correlated activity or the normally correlated activity changed under the drug. So if you click on, please. So here we've got the baseline connectivity. This is where activity is correlated to the seed region, which is the red here. So all this orange and yellow stuff, that's where activity is temporally correlated. That's where the spontaneous activity fluctuates synchronously over time with this seed region here. So here we see a network. This is actually called a default mode network, related to self-referencing and high-level sort of introspective functions. And we found that under the drug, activity in a key node of the network, this posterior cingulate cortex region, became essentially decoupled or desynchronized from the seed region here. So normally the network's tightly coupled. Under the drug, it becomes kind of fragmented. There's a sort of disintegration in the network. We looked at a different brain network. This one's concerned with sort of focused attention, goal-directed cognition, and we found the same principle. So this activity in this network became desynchronous, it became decoupled, and so essentially there was a kind of disintegration in the function of this network as well. So here we're seeing a general principle where activity within networks is becoming disintegrated. So when we look within the integrity of individual brain networks that usually serve specific functions, we see that the networks become disintegrated. They lose their integrity, which is, again, what you would infer from hub structures being primarily affected by the drug, knocking out this integrative function. So click on, please. So what does this mean? Well, one of our volunteers here said that everything became fragmented under psilocybin. Things were all in bits, and it was very hard to hold it all together into a coherent stream. Thank you. And so that's just to express what I've just described. If we click on, please. But it would be misleading to just tell you that there's decreased blood flow, decreased function in the brain, also decreased integrity in brain networks. Actually, one of the most recent analyses we've ran has looked at the variance in the spontaneous activity in the brain. So we look essentially at the sort of erratic nature of the signal, and this is a sort of simultaneously a measure of the changes in the amplitude of the spontaneous activity in the brain. When we ran this analysis, we found that there were actually increases in the amplitude of the spontaneous signal here. So this is just activity fluctuating spontaneously. Here's the drug infusion, and then you can see that there's a kind of erraticness and an increase in amplitude in the signal here. These are different subjects. And where did we find this effect? Well, it seemed to be localized to important limbic structures such as the hippocampus. This I found really intriguing because for a long time I've been interested in the hypothesis that the psychedelic state shares some similarities with rapid eye movement sleep, which is the stage of sleep in which we dream. There's a number of evidences to support that, which I haven't included in this talk because I know the focus is on psychiatry and therapeutic applications. But for instance, it was found in the 60s that LSD infused during sleep. So people are asleep, you infuse LSD, and then people would go into rapid eye movement sleep much more quickly. So there'd be a reduced latency to rapid eye movement sleep. And then if the individuals were woken up, they would report particularly vivid dreaming. So this is something that we want to look more closely at. Also in rapid eye movement sleep, you see increased activity in these same limbic regions. You also see decreased activity in high-level association regions, as we've seen with psilocybin. So there's a number of biological evidences coming together to suggest that there's some substance to this idea that the psychedelic state may be, to some extent, like a waking dream. So if we click on, that would also fit in terms of the history of use of psychedelics in psychotherapy, where the psychotherapeutic approach was primarily psychoanalytic or psychodynamic, working under the rationale that these drugs make manifest latent psychological material. So there's a reduction in sort of defensive strategies that a patient might engage to sort of suppress any difficult material. And so under the drug, this latent psychological material can emerge into consciousness. So again, when Freud said of dreaming that it's a raw road to the unconscious activities of the mind, people have actually said of psychedelics that they could be like a super highway to the unconscious, you know. So if we click on, please. This is another recent study we've ran, this time using magnetoencephalography, which is a bit like EEG, which measures fluctuating or oscillating activity in the cortex of the brain, neural groups oscillating in synchrony, and you pick up this signal from the scalp with EEG. You don't have that, you pick it up more directly from the cortex with MEG, so it has a little bit extra depth resolution than EEG. In this study, we had 15 healthy male volunteers, a mean age of 35, a similar design to the fMRI, where we have a pre-infusion baseline, drug goes in, and then we look at changes in the oscillatory activity post-infusion of the drug. So if we look at the results of this study, we found again that there were changes in one particular direction, and that was a decrease in oscillatory power. So what's oscillatory power? It's the amplitude of the oscillations. So if a particular frequency band, the neural groups are oscillating synchronously, then you would have a large amplitude because they're all contributing to this particular oscillatory rhythm. So essentially what we're seeing is that these oscillatory rhythms in the brain are becoming desynchronized under the drug. So rather than having this organized rhythmic structure, there's a disorganization and a desynchronization of that normal organized rhythmicity in the cortex. And what's interesting is that we found this effect in similar regions to where we saw decreased blood flow with fMRI. Also, we know that the serotonin 2A receptors that these drugs stimulate are in these regions. So the picture's becoming relatively cohesive here, that the drug's working on a particular serotonin receptor and it's targeting particular cortical regions to disorganize activity in those regions. So if we click on, please. We also looked at correlations between this desynchronous effect on the oscillatory rhythms in the brain and different subjective experiences. And so what we find is that some of these items, these are rated after the experience. The ones that were rated highest are those that refer to the sort of low-level perceptual changes, and particularly the visual perceptual changes. But the problem is we have a bit of a ceiling effect where most people are rating this around sort of top marks, like 100% essentially. But we have more sort of abstract and items in the center here, which have a wider variance. And so we can look to see whether the changes in brain activity can explain some of the variance in these experiences. So if we click, please. Click. There was one particular item which refers to ego disintegration, which is something that people often describe with psychedelics, this sense that their usual sort of confidence and assuredness in their sense of self is affected by the drug, particularly with higher doses. So this particular item there, I experienced disintegration of myself or ego. Yes, if we click on. When we looked at correlations between ratings of this item and changes in the alpha frequency, which is the frequency band where we saw the most marked changes, and then we look in this region where the decreases are particularly pronounced. So this is, think of the normal rhythmicity here becoming essentially kind of chaotic, and it's becoming desynchronous. So the magnitude of that effect is correlating with people's ratings of a disintegration in their sense of self or ego. Now that's quite intriguing because people have linked the alpha frequency and the alpha rhythm, the alpha oscillation, with developments in consciousness. So it's known that this rhythm is particularly pronounced, amplitude in this frequency band is particularly pronounced in humans. You won't find it, and it develops through maturation, so you won't find it in young infants. Essentially, you can't find it before the age of 3, and it develops into adulthood, and it's most pronounced in middle age. Like I said, it's particularly pronounced in humans. So they've made the speculation that there's something specific about this oscillation as being a marker of high-level cognition of the sort that adult humans have. So it's interesting that something which might be relatively unique to humans, that sense of having a absolute sense of self, albeit, this may well be an illusion, it is something which may be especially unique to humans, this ability to self-reflect. And so if the alpha oscillation is a marker of that, and we're seeing a drop in that, then that fits with the idea that this drop is related to a disintegration of the self or ego. So if we click on, please, this volunteer, one of our volunteers said after his experience that was real ego death stuff. I only existed as a concept, as an idea. So that's kind of suggesting he's lost all subjectivity and become something like an object in the outside world, something sort of inanimate and just there. It's a concept. It's no longer me with all the subjectivity that's entwined with that. And click. That's just a reference for the paper I was referring to, which is linking alpha to brain maturation and maturation of developments in consciousness. Click on, please. So what about the biological support for therapeutic applications? If we click here, there's lots of clicking with these slides. Medial prefrontal cortex, posterior cingulate cortex functional connectivity correlates with depressive symptomatology. So the more ruminative people are with depression, so these are patients with depression, the more they dwell on their symptoms and they contemplate how terrible they are and how terrible the world is, and they're stuck in their own heads, the more severe that particular symptom, the stronger will be the correlation between these two structures. And they're two hubs that I showed earlier on, a prefrontal one and the posterior cingulate cortex, which is more posterior in the brain. So the stronger, the tighter the coupling there, the more people will ruminate in depression. If we click on, this is just to remind you that when we looked at these two regions under psilocybin, we saw a reversal in that particular marker. These are healthy volunteers, but we did see a decrease in the functional connectivity between these regions. So things like this are kind of indirect support. They kind of imply that the drug is working in the brain in such a way that may be useful in depression because it reverses a particular marker of depressive symptomatology. So if we click on again, please. Other evidence to support the antidepressant potential of psilocybin. You find similar effects in meditation. I just want to move on relatively swiftly now. And we see decreased activity in the same regions with psilocybin, medial prefrontal regions. You're seeing decrease with meditation. Now, there are a number of different other treatments that are effective for depression, so lots of clicking here, I'm afraid. SSRIs, CBT, sleep deprivation, ECT, placebo, where it's effective, where people respond to placebo, deep brain stimulation, and ketamine. They all do the same thing, so they all decrease activity in this medial prefrontal region, which is generally elevated in depression. So in depression, activity here is up, and with all these different effective treatments for depression, and also psilocybin, which may be a treatment for depression, we see decreased activity in this particular region. So if we click on, please. Some work looking at the serotonin 2A receptor and its relationship to mood and depression, where we know that the serotonin 2A receptor is upregulated in depressed patients. Also, if you deplete serotonin in the brain, you'll see a probably functional upregulation of the receptor, because the endogenous ligand for that receptor is depleted in the synapse. So the receptor's essentially getting understimulated, so it will upregulate in order to compensate for that low synaptic serotonin. So you see that in serotonin depletion states. Now this is some nice PET work here. Let's look at this one first. This is looking at the serotonin 2A receptor binding. So using a ligand, a radioligand, which sticks to the serotonin 2A receptor, and then you can look at the density of the serotonin 2A receptor in the brain. So how strong is the signal? The stronger the signal, the higher the density of those receptors. So looking at that, there's a correlation between trait neuroticism and densities of the serotonin 2A receptors. So they're kind of they're sort of a marker of this low mood. And you see the same thing here, looking at trait pessimism in depression. The higher the density of serotonin 2A receptors, the higher the trait pessimism. So this upregulation of the serotonin 2A receptor may be a marker of this fixed cognition that you see in depression, where people are ruminating and stuck in their own heads, and they're pessimistic, and they can't get sort of excited and interested in things as well. So if we click here, this effect was particularly strong in the medial prefrontal cortex, again, linked in with previous findings. Also, we know that if you block the serotonin 2A receptor with ketanserin, then you'll see a significant attenuation in the positive mood effects of both psilocybin and MDMA. So this is saying that a deficient stimulation of the serotonin 2A receptor, leading to an upregulation of that receptor, so more of those receptors because they're getting understimulated, may be a marker of depression, and it may sort of offer the case that we should target that receptor to stimulate it, to try and reverse some of the phenotypes that we're seeing from understimulation of the receptor, which is probably rigid, fixed cognition. You stimulate the receptor, and you could promote flexible thinking, and this could be antidepressive. So if we click on, so this is the essential message. Deficient serotonin 2A stimulation may be a marker of pessimistic thinking. If we click on again, please. So using a lot of these evidences to support the case for doing a clinical trial looking at psilocybin and its efficacy for depression, we were fortunate to win this MRC grant to look at this. And so this is the design that we propose. We're on the cusp of getting approval, we hope, although it's been a very difficult, tough road. It's still not approved, but we're hoping we're at the latter stages of getting it through. So it's a placebo-controlled design, double-blind, between subjects, 60 patients, half of which will receive placebo, half of which will receive psilocybin, intravenous psilocybin. If we click on again, please. Males and females over 18, they've got relatively high, relatively severe depression, 17 plus on the HAM-D rating scale, and it's treatment resistant as well. They'll have failed at least 2 different antidepressant treatments as well, so they're not responding to the first line medication, the first line interventions. A lot of them will have had psychotherapy as well, probably CBT. Exclusion of current or previous diagnosed psychotic disorders, any immediate family history of psychotic disorder, and they need to be relatively healthy, need to pass our health assessments. No history of suicide attempts. Most patients will have suicidal ideation, but we want to minimize the risk of suicide. We won't have anyone who has attempted suicide, and no history of mania that fits in with no psychosis. Yep, click on. Very quickly, the design is we have screening, then we have a baseline MRI scan, looking at some of the measures I've described earlier. we have the first treatment session, which will be with a low dose. We'll have preparation and sort of integration sessions pre and post the treatment, so we're not just zapping them with the drug and leaving them to go about their merry way. And then we do another treatment session with a higher dose of psilocybin, similar preparation and debriefing. They have a follow-up the next day where we do a MRI scan to look at any changes in activity and whether that's going to correlate with any of the outcomes. And then we have a follow-up visit on day 25, a week after the second treatment. We also have other follow-ups, but there won't be visits unless there are indications for us to see them again. So that's a kind of efficient design. Primary outcomes, BDI, the Beck Depression Inventory. We can skip this. These are just standard rating scales of depression, so we can click on. What about the spiritual experiences? So this is the last segment of my talk. I hope I have time for it. What about spiritual experiences that people report with psychedelics? Here's Walter Stace, who wrote very nicely on the spiritual experience and trying to deconstruct it and look at different aspects of the spiritual experience, looking at different religions and people's experiences across these different religions. So he found that there was a particular experience which was common in all of the different religions. 10 minutes. And that was this description of a sense of being at one with the world, a sense of losing that usual distinction between the self and the environment. There was a kind of merging of that, and this was common whether you looked at Islam or Judaism or Christianity or Buddhism. When people had these profound, naturally occurring spiritual type experiences, they would often describe this sense of being at one with the world, a sense of a unitive experience. Now, if we click on, this is a long description from Freud, but it's nice because it describes this really well. I'm just thinking in the interest of time, I might skip on. I can give you my slide so you can read this nice description, but essentially he's describing this. Now, what could this rest on in the brain? It's difficult perhaps to think, that this has some biological basis, but, as a scientist, I believe that it has to, So there are two networks in the brain that serve kind of almost diametrically opposed functions. We have the default mode network, which is concerned with the sense of self, looking inwards, what we tend to do when we daydream and we stop focusing on the guy giving the lecture, for instance. And then you have another network which is concerned with just that, with focusing, with paying attention, with engaging in the outside world. Now, activity in these networks tends to follow a kind of anti-correlated or inversely correlated pattern, where when activity in the default mode network goes up, for instance, activity in the attention network will go down. So this function may serve the behavior and our ability to either fully engage on something or to essentially lose focus and start daydreaming. And it's functionally useful that these two behaviors should be kept separate, that they shouldn't merge together. And what would be the implication of if they did merge together? Well, you might predict that there would be a sense of losing oneself and losing this separation between the self and the environment. So you might predict that activity will become more correlated under a psychedelic drug, for instance. And that's what we find. So if we just show the results very quickly here, click please, we see an increase in the correlation between these networks that are usually not correlated and actually anti-correlated here. And we'll click on. And this is just showing you this in a single subject, his time series. You can see that the activity is becoming correlated under the drug, where previously it was orthogonal or not correlated at all. Click on, please. Yep. So click, please. So this is, again, to illustrate what this means. This is from Roland Griffith's work. He found a volunteer saying, the feeling of no boundaries, this is after a high dose of psilocybin, the feeling of no boundaries, I did not know where I ended and my surroundings began. Somehow I was able to comprehend what oneness is. So click please. So you find the same effect of decreased default mode, attention network competition or anti-correlation in schizophrenia. You see it in early psychosis and particularly in the at-risk mental state. You see it in meditation and particularly, click please, a form of meditation concerned with promoting this loss of separation between the self and the outside world, or non-dual awareness. Yes, click please. This is looking at, this sort of extending the analysis, not just looking at two networks, but all networks and how they relate to each other. This is pre-psilocybin, this is post, and this is the difference. And what I just want to emphasize is that these are a number of high-level networks that are usually uncorrelated, the kind of pale colors here. They become correlated under the drug. So what might this mean? And this is my penultimate slide, if you click, please. So one way to describe how these systems behave is that usually if we look at what's described as an attractor landscape, a system will reside in a particular state, and there may be a relatively clean and crisp and well-defined transition from one state to the other. And this is expressed by having a landscape that has these very high hills. So when one transitions from this state to here, for instance, it's quite easy to sort of reside there and be sort of firmly in that other state. Now, what would happen if we were to flatten this attractor landscape? Well, the ball here would be able to move much more freely, and there would be a sort of more entropic or disordered quality to the system. And that's what I'd like to use this really as a metaphor for describing what psychedelics are doing to the brain, that there's a kind of flattening of an attractor landscape. If we think of depression, for instance, that would be, go back please, that would be a particularly fixed state where the ball gets stuck in a particular depression, you know. Often these terms sort of have an origin which we don't really realize, that there's a kind of intuition about what the state is. So a literal depression where the mind is stuck in this pessimistic state. Now, if we were to give psilocybin, we might flatten the landscape and allow the ball to move out of that state, to move out of that being stuck in a rut like you see in depression. Similar principle might apply in addiction, for instance, where you see a very fixed behavior rather than a very fixed cognitive style. So where people are repeating over and over the same, they have the same compulsion. Again, in OCD, it would be the same thing, that people get stuck in a particular state where they have to go here, and they're kind of stuck in this trajectory here in addiction or with any other compulsion. So that's the principle I want to express there, really. And I've got 3 slides that I'm going to gloss over because they're difficult and we don't have time. I can provide the slides. This is a review article that I've written, which you may find interesting. Hopefully it's going to come out soon. It's actually in review at the moment, but it's really around this principle, which was touched on yesterday. I think Professor Carlini might talk about psychedelic drugs being best described as being a disordered state rather than this sort of crude description that we usually have of brain activity either being increased or decreased. It's not really that trajectory that we're looking at here. We're looking at ordered brain activity or disordered brain activity. And it's this disorder that I think we see with psychedelic drugs. So I think it fits in with that model. If we click on, please. This is just saying, sort of using the thermodynamic aspect of entropy, but entropy is a sort of universal principle that it's the same principle that applies in thermodynamics as applies in information theory, where entropy can either be disorder or the level of randomness in a system, but it can also be our level of uncertainty about the system if we go in and sample it. So in a more random system, we're more uncertain about the nature of the system. And again, that helps sort of describe some of the phenomenology of the psychedelic experience, where there is this increase in uncertainty, that usual assuredness that we have when we go about the world, sampling the world, that kind of confidence when we wake up in the morning that this is the way the world is. That's kind of shattered under a psychedelic, and the world becomes novel, it becomes strange. And this principle, I think, really helps to describe that. Similarly, I don't think it's too much of an extension to say, when people describe consciousness under psychedelics as being expanded, I actually think that the analogy of the expansion of a gas with an increase in entropy, there's more disorder here, there's more randomness, Here, with a constraint in the system, the gas is localized to this particular compartment. So if we were to sample it, we would have more confidence about where a particular gas molecule might be, for instance. We would say, well, it's going to be over here. But post-release of constraint, increase in entropy, we have more uncertainty when we go in and sample the state. And you also see an expansion of the gas. When people describe consciousness as being an expanded state, I don't actually think it's too much of a leap to make that connection. I think there's something there in terms of what's going on in the system, the repertoire of states that the mind can enter, that the brain can enter, actually becomes extended under a psychedelic. If we click again, please, this is a difficult slide. I would say let's keep that in case you're interested, and then this will be in the review paper, hopefully when it's published. But it's essentially saying that the psychedelic state, there are other states which share similarities, for instance, dreaming, magical thinking, also I think early psychosis. So it's not, it's a more complicated story than saying, oh, psychedelics are wonderful things that can cure depression and all these different illnesses. There are aspects of psychosis, I would say, that share similarities with the psychedelic state. But actually, in early psychosis, it's not always dysphoric. There are aspects of the experience where people might actually be sort of experiencing sometimes even mystical type experiences in these conversion states to psychosis, and they'll also have magical thinking. And so when consciousness changes in this direction, you see a certain sort of signature phenomenology, and I would argue that you see it in these different states. And this would be expressed by an increase in entropy in the system. There's a lot of other complicated issues like criticality, if you've ever heard of that may fit in here, but I would say let's keep that for the review paper and end there, I think. So if we go to the last slide, please. So just to say thank you very much for your attention. Thank you to David Nutt, my boss, for allowing me to do this research, and for Amanda Fielding, who has supported all of our research, and a lot of very helpful people who've helped me on the way. So thank you very much for your attention. Should I take questions, or how are we doing this?
Bom, a gente vai abrir para algumas perguntas. A gente está um pouquinho atrasado, então a gente vai fazer uma rodada, aproximadamente 5 perguntas, e a seguir ele responde todas de uma vez. Eu vou pedir para o pessoal ali em cima o microfone.
Dr. Robin, thanks for coming and sharing all this wonderful research. I have 2 questions. One is more technical and quick regarding the MEG experiment.
Yeah.
If you guys are looking to coherence and phase relations between the different frequencies. And in a more philosophical question is that in the 70s, Sidney Cohen talked about that psychiatry was trying to split consciousness in 2 and terming this the sane and the insane. And he suggested that psychiatry was maybe missing another realm that he termed unsane. And Stan Grof, later on, he coined the term holotropic to distinguish altered states that have a healing potential from the pathological states that don't have healing potential. So the question would be how you see these things in the current psychiatric paradigm, and what would be the differences between your neuroscientific findings of the psychedelic drugs from neuroscientific findings from psychopathological patients?
Yeah, well, it's a really good question. The first one I could answer quite quickly about coherence. The chap who led the analysis with the MEG is of the view, and others share it, that by looking at oscillatory power and seeing decreases, by implication you would have a decrease in coherence. So he argues that we don't want to be too circular with what we report, because it's already implied in seeing a cortical desynchrony that you're naturally going to see, and seeing a drop in amplitude, that by implication already you're going to see a drop in coherence. I think there are complicated ways where you could sort of take that into consideration, that you're seeing a drop in amplitude, but he's kind of sidestepped my eagerness actually to do coherence analyses. But we'll see. Now, the other issue about unsanity, or there being, being too simplistic to talk about sanity and insanity, I think it's a really good one, because schizophrenia is an incredibly, heterogeneous disorder. It's a bit of a cliche to say that now, but it's because it's really true. And actually in fixed psychosis, where you see fixed delusions, it's a very different state to early psychosis, I would argue, where the phenomenology is quite different. And actually, I think, in fixed psychosis, in fixed schizophrenia, especially when there's negative symptoms and things are developed along that course, the disorder is much more intransigent. It's much harder to treat. Whereas within the early phase, I think there's a plasticity to the system, at least if there's overlap between the phenomenology of the psychedelic state and the phenomenology of early psychosis, and we're seeing evidence for a unconstrained cognition and a kind of flexibility in the system, then that might imply, and adding to that, where it's promoted that psychedelic experiences, it's really, strongly emphasized that they should be mediated in a particular way, that you need to promote this positive setting, you need to be there for an individual if they experience difficult material and work through that. And so if there's this overlap there between the psychedelic state and early psychosis, then why don't we mediate early psychosis in the same way? Treat it like a psychedelic experience, where you have to mediate the experience and guide someone through that experience. So that's very Langian, but I like R.D. Laing. At least I like that aspect of his thinking. So I'm receptive to the idea that there's a kind of window of opportunity in early psychosis, where you could even, to say it's not a pathology might not be quite fair, because usually people are experiencing distress when in early psychosis. However, if someone was to take a psychedelic without knowledge, then you would expect distress, right? So for me, the connection is quite strong, and I think it supports the case that you could use psychedelics and the phenomenology as a sort of support for the idea that you can mediate early psychosis.
Hi, thank you for your talk. I'm particularly interested in dissociative states, either pathological ones or controlled in mystical experiences and mystical trance and possessions and stuff like that. And there are some similarities with the psychedelic experience and also with the early psychosis experiences as well. So I'd like to hear from you a little bit about what you think about the study of psychedelics might give some light on the knowledge of dissociative experiences.
On dissociative
experiences and dissociative disorders as well.
Okay.
Thank you.
Well, it's a tricky one. I mean, there are other psychoactive drugs that are more typically dissociative, like ketamine, salvia. You might want to respond, whereas psychedelics, I wouldn't really say that it's a dissociation as such. In fact, people,
Yeah, I'm not talking dissociation in terms of, dissociative drugs, but the experience of, splitting one consciousness and sometimes having, the feeling of the separation of there is a separate ego looking at yourself, and this is quite common in the ayahuasca experience. But also it might happen in other psychedelics. I'm not talking. I'm really talking about the serotonin, and not necessarily.
Okay, so I think it's just an issue around the sort of language, but a dissociative experience that could occur in. Personally, I wouldn't call it a dissociative experience. You might call it. unitive experience or something, where rather than it being a split, it's actually a coming together of things that are usually split, like the self being split from this podium, say. It would feel like this was almost part of me, say, under a psychedelic. But as I've said, I think that there's a strong link between spontaneous spiritual experiences that would occur without a drug that you might see in meditation, you might see in with other things that would promote that, like as it's promoted on a spiritual retreat, say, sensory deprivation, this kind of thing, as well. I think there are a number of different ways of causing a system, thinking about this mechanistically, to become unconstrained. You can take away the anchorage to sensory input, for instance, with sensory stimulation. A similar thing's probably happening with a psychedelic, where you're no longer anchored to the outside world. And what happens then is the system loses its order because it doesn't have that anchorage. And so it becomes more entropic, becomes more chaotic. Maybe I've gone a little off topic there, but I don't know if that was useful at all. One thing I would want to say, actually, the difficult stuff around criticality, I think is particularly interesting, because there are certain signatures of a critical system. So a critical system is one that's kind of positioned in a critical place between two extremes of order and chaos. And within this particular critical position, you see a level of organization, kind of spontaneous organization often. And then with this self-organized criticality, as it's described, there are certain signatures of a system which exhibits it. And actually, most systems in nature exhibit self-organized criticality. And one thing that I'm particularly interested in is that the human brain and the mature human brain might actually be slightly shifted, and there's a little bit of evidence for this, shifted towards the direction of being slightly what they call subcritical, or actually towards the pole of being a little bit more ordered than being perfectly positioned at sort of at this critical point. And so what that would imply is that the system becomes a little bit more ordered and a little less flexible than it would be if it was at criticality proper. And some of the signatures that you see of a critical system are things like sensitivity to perturbation. So if you kick the system, then that effect reverberates, and it has a particularly pronounced effect. You also see spontaneous cascading or propagating or avalanche behavior in the system. So some of the aspects of the psychedelic experience that are particularly intriguing and different to consciousness, and sort of suggestive not of a state of consciousness that's reduced, but actually potentially a state of consciousness that's kind of expanded in some sense and has a broader repertoire, would fit with the idea that the system moves from subcriticality in normal waking consciousness into criticality proper, perhaps. So the increase in entropy doesn't just mean that the system becomes chaotic, it becomes actually potentially critical. And that might explain a few other things. And also, this is, again, one of those slightly tenuous leaps, but one that I particularly like because it has an intuitive appeal. When most of nature exhibits self-organized criticality, and if under a psychedelic state you can take the brain from subcriticality to criticality proper, then you have a system which is closer in behavior to the rest of nature, potentially hence why people romanticize the psychedelic experience so much and say, under a psychedelic, it's like being closer to nature. I don't know, slightly tenuous, but I like it.
Bom, a gente vai ter um coffee break agora. Vamos encerrar. Muito obrigado, Robin. Excelente palestra. Bom dia. Agradecer a presença de todos. Agradecer o Dr. Robin Carhart-Harris, que aceitou gentilmente o nosso convite. O Robin ele tem doutorado em psicofarmacologia pela Universidade de Bristol e hoje é pesquisador, pós-doutorando do Centro de Neuropsicofarmacologia da Universidade do Imperial College London, de Londres, né? Ele coordena um projeto intitulado Psilocibina para a depressão. A psilocibina, para aqueles, se alguém não conhece, é um princípio ativo dos cogumelos do gênero Psilocybis, né, os chamados cogumelos mágicos, e eles têm desenvolvido pesquisas muito interessantes com ressonância magnética funcional. Ele vai explicar para a gente agora. Então, Robin, por gentileza.
Okay, well, thank you very much for the invitation, Hoffman, who is the chap, the Swiss chemist who is most famous for discovering LSD. And Hoffman was the first to isolate the psychoactive ingredients of magic mushrooms, psilocybin, and its metabolite, psilocin. So in 1959, Hoffman also synthesized psilocybin, and in 1962, Wasson invited Hoffman to travel to Mexico, and they actually provided Maria Sabina with the isolated, pure, synthesized psilocybin, and she was quite skeptical. She thought, this is going to be quite different to the mushroom experience. There's something special about the mushrooms, and this pure ingredients of the mushrooms isn't going to produce the same effects, but in fact it did. They actually gave her quite a large dose, 30 milligrams, and she said, yes, this is essentially identical to the mushrooms. So next slide, please. So some more scientific background. First of all, I've already said psilocybin is found in magic mushrooms. That's a liberty cap mushroom. Here are the molecular structures. Now, psilocin is the metabolite of psilocybin. Psilocybin is the more stable phosphorylated ester of psilocin. So it's psilocybin we work with really because of its stability. But as soon as it's in the blood, it seems it's broken down into psilocin. And it's this that works on serotonin receptors in the brain, as I'll talk about in a moment, which is the first stage of the mechanism of action of psilocybin and psilocin. Here are some other structures. DMT, that's found in ayahuasca. Bufotenine, that's found in some toads that secrete bufotenine, and it's another psychedelic substance. And what's remarkable when you look at these structures is their similarity to this very important endogenous neurotransmitter, serotonin. So if we look at bufotenine, it's essentially the same apart from this dimethyl group here. So it's remarkable that such a subtle change in molecular structure can confer such profound effects on consciousness when these compounds are given, and yet there's serotonin floating around in the brain doing all these fundamental functions. Down here we have, this was a finding in the late 1980s, and really it was a very crucial finding in the understanding of how these drugs work in the brain. And it was found that the affinity or the stickiness of a psychedelic drug for a particular serotonin receptor, the serotonin 2A receptor, correlated with its potency. So the more sticky or the higher affinity the psychedelic, the more potent it is. And to help illustrate that, LSD is a good example. It has a very high affinity for the serotonin 2A receptor, and it's incredibly potent. So in doses as low as 20 micrograms, it's psychoactive. Okay, next one, please. And it's also been found that if you block the serotonin 2A receptor with ketanserin, a relatively selective serotonin 2A receptor antagonist or blocker, then you'll significantly attenuate the key psychedelic effects of psilocybin in humans. Now, where is the serotonin 2A receptor? Well, it's very much a cortical receptor. It's expressed in relatively low concentrations in subcortical regions, but it's densely expressed in the cortex, and importantly, particularly highly in high-level cortical regions concerned with high-level cognitive functions, such as the posterior cingulate cortex, and that will become quite important as we go on. Most of my work is neuroscientific, so that's what I'll be presenting, really, how these drugs work in the brain and what we learn about that in terms of implications for applications in psychiatry. But another little bit of background, it's interesting to know where the term psychedelic comes from. Psilocybin is a classic psychedelic drug, like LSD, like DMT. It's really these serotonergic hallucinogens that are referred to as classic psychedelic drugs. So psychedelic is a term that was coined in conversation between the famous author Aldous Huxley and a psychiatrist working with LSD in the 1950s, Humphrey Osmond, and they were looking for a better term that could really sort of capture the essence of what it is that these drugs do. Huxley came up with a term, but it was a little bit clumsy, and Osmond suggested combining the terms for soul or mind, psyche, and delicy to make visible or clear. So it was from that they came up with the term psychedelics, which literally means mind manifestors or soul revealers. So already sort of inherent in this term is what these drugs are doing psychologically, that they sort of allow for the emergence of psychological material that is usually kept from consciousness. So they make manifest latent psychological contents. So that's what these people wanted to communicate to people in terms of the name for the drug. So the next slide, please. So this is Stanislav Grof, who did a lot of work with LSD in the 1960s, and he comes up with some great comments in his books, and they're often quite grandiose, but they're useful for expressing why these drugs are so interesting. And so he said of psychedelics that used responsibly and with proper caution would be for psychiatry what the microscope is for biology or the telescope for astronomy. These tools make it possible to study important processes that under normal circumstances are not available for direct observation. So what a incredibly grandiose claim to make a sort of a link between psychedelics in psychiatry being equivalent to what the microscope has been for biology. But if there was even any sort of glimmer of truth in this, it's an incredibly important matter, and it really supports why I be here. It's a real pleasure to speak to you. Hopefully you'll find my research interesting, and hopefully it might inspire some of you to look into this area yourself. So let's see how we go with the pointer thing. Where should I be pointing this? It doesn't seem to be working. Sorry? Oh, really? Okay, yeah. So, here we go. It's working now. So just to begin, I'll give a little bit of background on psilocybin. So first of all, this isn't going to be very easy. So it was, it's had thousands of years of ceremonial use. Next click, please. There's going to be lots of clicking, unfortunately, and this isn't going to work very easily. So before 1957, Gordon Wasson, who was actually vice president of JP Morgan in the US, a banker, he was also an amateur mycologist and had an interest in mushrooms and learnt about psilocybe mushrooms and their ceremonial use in Mexico. And so with his wife, he went on an expedition to Mexico in search of these of the ceremonial use of magic mushrooms, and it was there that he met the now famous curandera Maria Sabina, and he had an experience with psilocybe magic mushrooms. Click, please. Yes, so in 1957 there was a famous article in Time magazine where he documented his experience in Mexico with Maria Sabina. Click, please. In 1958, they cultured some psilocybe mushrooms and provided them to Albert